Hi, everyone. We are really excited to be here to talk about some of our work on mental health crisis response systems. Specifically today, we're going to be talking about an early multi-stage research project looking at geographic overlap in non-police crisis response programs. So to get started, we just wanted to quickly introduce ourselves. I'm Amanda. I'm an assistant professor at the University of Maryland College Park in the School of Public Health. I spend most of my time thinking about non-police crisis response, specifically mobile crisis teams that are housed within certified community behavioral health clinics. And we'll be talking a lot about CCBHCs. And with that, I'll turn it over to my co-presenter.
Hello, everyone. My name is Therese Todd. I hold a PhD in clinical and forensic psychology. I'm a licensed clinical psychologist and researcher, and I'm currently a faculty fellow at the NYU School of Law and the Policing Project. My research broadly focuses on the criminalization of mental illness and how police and communities respond to mental health crises. Today, we're going to get started with talking a little bit about the background of this issue on crisis response. And we know many of you really provide services in this area, are practitioners, and are really grounded in this work. But we just wanted to start with some background on the issue to get us started and make sure we're all on the same page as we get our presentation underway. So, with that, thinking about crisis response and mental health services in the United States, Lost Patients is a podcast through NPR. And if you haven't listened, I recommend it. But it tells a story of those who have been left behind by America's healthcare system, a story of those with chronic mental illness, substance use issues, experiences of being unhoused, who have been left with nowhere to go and continue to end up in the criminal legal system, or what Lost Patients calls the churn. Following deinstitutionalization, which happened in the 1970s with the closing of inpatient hospitals across the country, we were left with a gap in systems where desires and aspirations for community mental health care to fill that gap never happened, and the legal system became this catch-all. And as a result, this criminal legal system became overwhelmingly responsible for addressing societal issues, and police officers became known as street side psychiatrists or street side mental health professionals. And as a result, we have a system where police are frequently interacting with people with mental illness and people in crisis. In the United States, it's estimated that about 10% of police encounters involve a person with mental illness or experiencing a mental health crisis. And this might occur through a variety of mechanisms like complaints, street checks, wellness visits, tickets. And this is really important because research has found that once those with mental illness come into contact with the police, they are more likely to have continued criminal legal involvement. In terms of arrest occurs in about 10 to 20% of police encounters with people with mental illness. And research does find that those with mental illness are more likely to be arrested for lower level offenses than those without. And so when this happens, it's not that individuals experiencing crises or mental health symptoms are enacting severe or violent behavior and offenses, but really low level misdemeanors that others would likely not be arrested for, like crimes of poverty or survival. And when people experiencing mental health crises interact with the police, their outcomes might include arrest or emergency detention or the result of emergency detention of involuntary commitment, referral to service, or even just no action. In one of my research projects, I looked at 3 years worth of crisis response data from the Seattle Police Department, consisting of almost 20,000 incidents from the years of 2015 to 2018. And one notable finding from this work was that 78% of all mental health crisis incidents that were indicated by that responding officer, they were nothing more than just that, a mental health crisis. So there was no criminal behavior involved. And this really begs the question of why are police responding in the first place? Unfortunately, research also shows that people experiencing signs of mental illness are more likely to receive higher levels of force from law enforcement, even when controlling for other relevant factors. And too often, this results in death. I'm briefly going to show some data from one of Amanda and I's recent papers. It's currently under review and demonstrates just how great that risk is for folks exhibiting signs of mental illness. And these results may be a bit jarring, so I just wanted to comment on that before jumping in. So, a paper from 2018 found that people displaying signs of mental illness were over 7 times more likely to be killed by the police than those without. And this was looking at just 1 year of police killings in 2015. Amanda and I replicated this finding using 11 years worth of police killings from the Mapping Police database. And this is a publicly available data source which aggregates its data or collects its data from media sources. And researchers could then code these incidents to determine if an encounter might have involved signs of mental illness or not. And that same coding procedure is done with determining the subject's race as well. So, in this project, we looked at over 9,000 police killings from 2013 to 2023, and then calculated the relative risk of being killed by the police for those exhibiting signs of mental illness to those without. And we looked at that total sample and then broke it down by different demographics, including race. Because so much of the work in this space has looked at use of force outcomes in a way that doesn't account for when the two marginalized identities of mental illness and race intersect. So, realizing this gap and the heightened risk of police violence for communities of color and people with mental illness, we wanted to understand how intersecting marginalized identities impact the likelihood of being killed by the police. And we found that Black people with mental illness are over 6 times more likely to be killed by the police than Black people without mental illness. But this raw comparison alone doesn't take into account the already elevated risk that Black people face of being killed by the police. And it might even appear that this risk is not uniquely greater for this group. And so, to get at this, we compared Black people with mental illness to white people without mental illness. And we found that the relative risk is 19-fold. These numbers are striking and devastating, and they're more than numbers, they're lives lost. Ultimately, together, this research, this body of work shows that we're sending out an intervention that not only doesn't fit the problem, but that's also causing more harm to those most in need of help. And I know I'm speaking to the choir here, but in any well-functioning system, the response should match the need. We don't send electricians to deliver babies or fix broken bones. So why do we send police to respond to mental health crises? Considering this, I briefly wanted to touch on the two models of police-involved crisis response before we then talk about our non-police programs that we're going to focus on today. And so the first traditional model of police involvement in mental health crisis is police officers receiving what's called crisis intervention team training. This is often a 40-hour mental health training. However, it's a bit unclear to what extent officers in any department receive this training or how widely it's available. But more importantly, the research in this space is quite limited and mixed, and we do not see an impact on tangible outcomes that we might be most interested in, such as reducing arrests, improving officer and subject safety, or reducing use of force. The other model is where we start to bring in non-police mental health professionals, and that's a co-response model where a police officer and a mental health provider are paired in their responses to 911 calls. And unfortunately, these are not always available 24/7. There may be a limited number of teams in any given department, and the models do vary quite widely. And again, most importantly, the research in this space is quite limited and mixed. So now Amanda is going to start the conversation about what non-police crisis response models look like.
Thanks so much, Therese. So in response to everything that Therese just shared with us, there's really been a significant expansion of non-police crisis response models. And in this presentation, we're going to focus on two types, the first being certified community behavioral health clinics, or CCBHCs, and the second one being community safety response programs, or CSRs. At the same time, we want to recognize that these are not the only providers operating in this space. There are many grassroots organizations and other private entities that are also delivering non-police crisis response services. However, for the purpose of this analysis that we're going to be talking about today, we do focus on CCBHCs and CSRs, but our broader goal is really to situate these models within the larger ecosystem of non-police crisis response. And now I'm going to turn it back to Therese for an overview of CSRs.
So to start off talking about community safety response programs, in 2020, the system really reached a boiling point following the murder of George Floyd and several other highly publicized killings of people experiencing mental health crises by police, such as Daniel Prude in Rochester, New York, and Walter Wallace in Philadelphia. Police are trained in compliance, see things as crime, are trained to look for crime, and are not trained in connecting people to care or have limited training in mental health crisis response, as I mentioned. So, communities across the globe really began to call for an alternative to police response. And since then, the result has been the emergence of non police alternative community safety response programs across the US. These programs typically include, or hold on a second. And Amanda, these are going to be like the click things. So I also animated your slides like that, where each bullet point will come up.
Got it. Okay, you want to start from the top then?
We can start from the top of this slide.
Okay.
Yeah, perfect. So these programs to fit our definition of a community safety response program, and currently there's a lot of conversation in the field of what should these programs even be called and what meet the criteria. But first, they should provide an emergency first response service, and that means that they get to a call within maximum an hour of that call, but often it's much less. They're typically run by local governments, are commonly dispatched through 911, although many also use other call lines as well, receive calls from third-party callers, and consist of multidisciplinary teams of mental health professionals, EMTs, and or peer specialists. We're going to come back to these characteristics a little bit later as we compare the programs I'm talking about with the ones that Amanda's going to share with you all now.
Great. Thanks, Therese. So beginning with CCBHC's role in their in the non-police crisis response space. What are CCBHCs first? So CCBHCs are primarily outpatient providers of mental health and substance use disorder treatment services that have to meet federal criteria related to the delivery of 9 categories of required services. And one of those required services is mobile crisis response. And the federal criteria are quite broad in what the mobile crisis service requirements actually mandate of the CCBHC, but there's some important requirements. So first and foremost, all services have to be available 24/7. They have to arrive within 1 hour or 2 hour within rural and frontier communities. Services must be provided to any individual within the service area, regardless of ability to pay. And mobile crisis response must be delivered directly, so by the CCBHC directly, or through certified, licensed, or state-sanctioned providers of mobile crisis response. So what does CCBHC access look like nationally? Well, we see substantial variation across the country. Overall, a little more than 40% of counties are served by CCBHC. And because mobile crisis response is a required service under the CCBHC model, this means that residents in these counties, so roughly 60% of the US population, should have access to a CCBHC affiliated mobile crisis team. But what the map also teaches us is that it's not evenly distributed. So some states have effectively universal CCBHC coverage, meaning every county in that state is served. So we can see Texas, Missouri, Kansas, Oklahoma are examples of those states. And then at the other end of the spectrum, some states have absolutely no CCBHC access, including South Dakota, North Dakota, and Delaware. But what we see is much more common is that most states are somewhere in between those extremes, with a share of their counties being served by CCBHCs, and a large portion also not being served. And then over time, we've seen a really dramatic expansion in CCBHC coverage. So when the first clinics were designated in 2016, fewer than 2% of counties and about a similar share of the US population was served by CCBHC. But today, that number exceeds 40% of counties and roughly 60% of the US population. And because mobile crisis response, as I noted earlier, is a required CCBHC service category, and because many organizations actually added mobile crisis response in order to fulfill the CCBHC criteria because of some special Medicaid payments that are associated with the CCBHC model, this growth likely represents an increase in access to mobile crisis services nationwide. So we wanted to emphasize here that there are likely really important differences between the two organizational types that we're focused on in this project. But before we really dig into them, we want to note that this slide, this brief conversation, is based on our experience working with these organizations to better understand how they offer non-police crisis response. And we really look forward to future work that is better to understand if these differences are truly generalizable across these two populations of non-police crisis responders. And with that, we just wanted to pull out some notable differences that we're beginning to see. So to start with the organizational setting, CCBHCs, for instance, typically reside in outpatient providers of mental health and substance use disorder treatment services. So they're mobile crisis teams. That's where they're sitting. We're seeing some development here with hospitals and FQHCs also, or which are primary care providers, also gaining CCBHC status and having to offer mobile crisis services themselves. But generally, when we're thinking about CCBHCs, we're thinking about a healthcare provider is where the mobile crisis team sits.
In contrast, community safety response programs are typically a unit of local government or a service contracted by the local government. And so these might be called public safety anchor institutions, which Bureau Institute of Justice defines as a government agency, department, or office that is responsible for the development, coordination, and implementing that jurisdiction's comprehensive public safety approach. And the next piece is looking at primary funding mechanisms.
So here's another area where we're starting to see important differences. It appears that CCBHC mobile crisis teams are largely funded by Medicaid, as well as other payers and grants, which is fundamentally different than the way that CSR programs are financed.
At this point, Amanda and I actually aren't aware of an example of a community safety response program that is using Medicaid for reimbursements. So please share with us if you have heard of one. But typically, community safety response programs are funded through a government budget line item and local taxes of that jurisdiction.
Another area where we're where we're suspecting kind of large differences is dispatch mechanism. So in the CCBHC space, this is kind of unknown. How do you access a CCBHC mobile crisis team? And why it's kind of unknown is there's such variation across organizations. And we're seeing teams dispatched by 988, 911, 211, 311, private lines, as well as other national lines. And we're actually doing some work right now to really start better understanding what is the exact dispatch mechanism by which CCBHC mobile crisis teams are accessed.
Great point, Amanda. And I love that our work complements each other so well. We're also working on efforts to understand what call lines and how these call lines are used by community safety response programs. It does appear that widely the most common call type is through 911. However, these programs also use non-emergency numbers, private numbers, as well as 988. But it still remains unclear how it varies from program to program for CSR programs.
And then finally, the other distinction that we wanted to point out is call type. It appears that there are some substantial differences here where CCBHC mobile crisis teams are typically responded to what we would think of as a mental health crisis call, whereas my understanding of the CSR space is it's a little bit more broad.
Definitely. So, as I mentioned, these programs really started to pop up post 2020 in response to police violence and as looking for a solution to addressing mental health crises that didn't involve police. And so, although the impetus for these programs was related to mental health crisis response, we're also seeing that these teams can respond to a variety of quality of life related calls, things related to substance use, housing, interpersonal conflicts, that sort of thing, low level offenses, and that all, are safe for responders to come to. Another important piece of this, which I think is still a question that this work and future steps hopes to address, is understanding the role of third party callers. And certainly community safety response programs receive calls from third party callers as they primarily use 911. However, I think it remains unclear to what extent other mobile crisis teams can receive calls from third parties and respond to incidents where the caller themselves is not the one receiving services. So we also see that as a future point of inquiry.
Thanks, Therese. Yeah, we were talking about that the other day and how we needed to better investigate third-party callers in the CCBHC space too. So with that, we wanted to emphasize something that we've noticed. So despite both of these organizational types playing critically important roles in crisis response across the country, and despite the likely meaningful differences between them, the existing scholarship and policy conversations are deeply siloed. So Therese and I first realized this when we were working at the same institution and became close friends and colleagues. And we were talking about our research, and we recognized the substantial overlap in our interest in alternatives to police-led crisis response. And yet the professional and policy spaces that we occupied were not talking with each other. So for example, most of my work is on CCBHC mobile crisis teams, but a lot of my research and that of many others in this space rarely engages with what is happening with CSR programs, and how these programs might be shaping how CCBHCs deliver crisis care. Even at conferences where I spend a lot of time talking about CCBHCs and crisis response, like CrisisCon and NatCon, seldom meaningfully engage with CSR programs. And I believe the reverse is true.
Definitely. I think one, piece that you coming to the alternative response convening and in my conversations with you was learning about just the vast variety of mobile crisis teams that are out there. A lot of work is being done on in the research side of things to start to landscape the field a little bit more and to learn more about where these programs exist, how they differ, how they're defined, what services they provide. But we're still seeing that it seems like we're in these early stages here. So this project is one of the first steps in understanding um, how these programs interact with each other in terms of just where they're existing at the national level.
Exactly. And the one point I want to emphasize here is, um, this siloing that we're talking about at the national level doesn't necessarily mean that there aren't conversations happening at local levels. In fact, I suspect the opposite is likely true, in that local providers are likely acutely aware of the other organizations that are providing crisis services in their communities. These might be positive relationships or negative relationships. That's an open question. But what we're seeing is that this gap in the conversation is really at the national level, with policymakers, researchers, advocates, other stakeholders that are really interested in expanding non-police crisis response systems more broadly. So with that, we arrived at this general research question, which really aims to answer: how are responsibilities for mental health crisis response allocated across non-police crisis response providers at the local level, and what factors explain this variation? And we argue that understanding how responsibilities are distributed across non-police crisis responders is really essential for understanding system design and its implications for access, quality, equity, and many other outcomes for individuals who are experiencing mental health crises. So to answer this question, we designed this mixed method studies with multiple components, and we'll get to them at the end. But we're going to start with what might seem like a really simple question. So where are non-police crisis response teams, and where do their service areas overlap? Now, as I said, this may seem super basic, but it actually remains quite an open question. We do not yet know whether these programs operate in overlapping or separate geographic areas, which is really essential for answering our broader inquiry related to how responsibilities are divided and what are the implications of those divisions. In order to answer this broader question, we first really need to understand where providers have the opportunity to share responsibility because they're located in similar communities. And so to do that, we needed to identify where non-police crisis response programs operate. And we achieved that by combining two data sets. The first is a data set we created on counties served by CCBHC. And we did this by searching federal grants databases and working directly with state officials. The data set is actually longitudinal, but for the sake of this project, we're just looking at a January 2026 cross-section. And then the second data set is a data set on community safety response program that we borrowed from the Center for Policing Equity. Thank you very much. We really are grateful for your work, which includes the county in which the CSR program is located. And importantly, they only include programs that meet select criteria, and I'm just going to quickly outline. So the program has to have been officially established. Responders are non-police personnel. Responses are on scene. Responses are first response as opposed to secondary. And responses are to urgent as well as non-urgent situations that police would otherwise handle. So then we link these two data sets at the county level to characterize counties into non-police response configurations. And we're interested in four primary types. The first are what we call non-counties, which are not served by a CCBHC or a CSR program. The second are CCBHC only counties, which are only served by a CCBHC but not a CSR. The third are CSR only counties, right? So the opposite, only served by CSR but not a CCBHC. And then the fourth are CCBHC CSR counties, which are served by both. Now, within this fourth category, we're interested in two subsets. The first is what we call CCBHC CSR integrated, which is when the county is served by a response team that is both a CCBHC and a CSR. And then the second subset within this fourth category is CCBHC CSR fragmented, which is when the county is served by different teams. So at least one of those teams has to be a CCBHC and the other being a CSR program. So we're going to present some very high-level early descriptive work on these non-police crisis response configurations at the county level. So first, we wanted to share the number and share of counties in these different configurations. So almost half of counties, 45%, are not served by either type. This is that none category. About 15% are served by only a CSR program. About 25%, so slightly more, are only served by CCBHCs. But then a fifth of counties are served by both. Excuse me, not a fifth of counties. About 18% are served by both. Next, we wanted to visualize, where are these county types? So when you look at this map, you can see that there are some patterns that emerge. So beginning with these white counties that are not served by either a CCBHC mobile crisis team or a CSR program, there's a lot of them, and they're kind of randomly distributed across the country. The second point is that counties that have a CSR program but not a CCBHC, these are the ones in purple, tend to be also geographically scattered, but there's some notable exceptions, right? States like Nevada, Tennessee, and Georgia, we see broader coverage, and we suspect that this is largely driven by statewide CSR initiatives. The third category is in red. Now, these are the counties that are only served by CCBHC. Again, we see kind of scattered, but also some clear concentrations in Kansas, Oklahoma, and Missouri, which also makes sense. And that's because these states have universal CCBHC coverage, so meaning every county in those states is served by CCBHC. And then finally, in orange, we have these counties that are served by both a CSR and a CCBHC. And again, some scattering, but also exceptions, right? Large orange populations in Texas, Minnesota, and New Jersey. And these states have statewide CSR initiatives, as well as widespread CCBHC access, which we think might explain why so many counties are served by both non-police crisis response types. And then the final set of results we wanted to present just digs a little bit more into the 551 counties that are served by both CCBHCs and CSR providers. These were the counties in orange, just to reflect back on the map. The first is, and we want to focus on the two subsets that I talked about earlier. So CCBHC, CSR integrated. So this occurs when a county is served by a single organization that operates both as a CCBHC and a CSR. And the second is CCBHC, CSR fragmented, which is when the county is served by different entities. So at least one CCBHC and at least one CSR. And when we look at this all column right here, we can see that the majority, 57%, fall in the integrated category, and only 20% of counties are served by organizations in the fragmented category, meaning crisis response responsibilities are divided across multiple organizations. But some really interesting patterns emerge when we look at the state policy context. So for the sake of this slide, we just focus on whether or not the state has a statewide CSR initiative. What we find is that in states without a statewide CSR program, roughly 2/3 of counties exhibit a fragmented configuration. But in states with a CSR initiative, about 2/3 are in the integrated category. Now, why we bring this up, and this is just a hypothesis, it suggests that state level policy design might be playing some type of coordinating role in shaping whether CCBHC and CSR functions are consolidated or divided across entities. And then in terms of next steps, as I said, this is the first step of a much broader project. So we're going to begin by looking at the structural and demographic features that are associated with each of these non-police response configurations, looking at things like rurality, racial composition and segregation, concentration of psychiatric services, police FTE, budget, homicide rate, things like that. We also want to spend a little more time looking at the role of some of these statewide initiatives. It seems like from our early results that states that are investing in both CSR initiatives and CCBHCs at the state level might be distinct from those that don't have these broader state level programs. And then we're also going to be doing some qualitative work.
Yeah, and just before I jump into that, one important thing that this data really shows us is that almost 50% of counties in the US don't appear to be served by either of these programs. And so more work is needed to understand what's happening in those areas, what's available, and if other services that we aren't aware of aren't available, why is that? And how can we use this work to better support those communities?
Yeah.
And also, how can researchers work together to better understand what's happening in these areas? Because right now, this is sort of like an unknown blind spot of this work. So thinking a little bit more about our other future work and focusing on qualitative interviews, we are interested in conducting interviews with organizations that are the sole non-police crisis response providers in their communities to understand how their responsibilities are structured, the services they provide when there aren't other mobile services available. We also will begin interviews with organizations that serve communities with multiple non-police response programs to understand how they interact, partner, work together, or don't, and how those responsibilities are divided across these programs to get a sense of are they serving the same or different populations and providing different services. I'll let Amanda close us out. Thank you all so much. We really enjoyed sharing this with you.
And thank you. Yeah, just to reiterate what Therese said, these are our emails. Please feel free to reach out to us if you have any questions or comments or just would like to share anything. Thank you.